Prostate cancer is treated curatively in three major ways. Surgery, of course, can be considered for selected cases. Surgery involves radical prostatectomy, but that can be done in today's world utilizing a robotic technique that decreases the side effects and acute difficulties related to the surgery. It still has significant risks and potential for long-term difficulties related to urinary control and issues such as that, but the process of prostatectomy is much better today than it was even 10 and 15 years ago. Equivalent to prostatectomy would be the aggressive approaches that we have today in radiation. The most commonly used radiation technique is external beam irradiation. The most common technique of treating prostate cancer with external beam radiation today is the use of intensity modulated radiation therapy, or IMRT. This is a technique that the beam of radiation actually comes into the patient from externally. They are lying on a table and the beam is projected through 5 to 7 different fields, and the radiation beam actually changes as the beam is on in each position. The daily dose of radiation is actually pretty high. It's an X-ray beam, just like getting a chest X-ray is an X-ray beam, but it's tens of thousands of times stronger. It's very well controlled. It goes exactly where we want it to go. We know exactly what to expect from it because of all of the detail that goes into the treatment planning before we turn the beam on. We know that the machine's going to deliver the dose that we tell it to do. So it is important for us to keep the beam exactly controlled, exactly where we want it. Very fine detail every day that a person comes in for radiation therapy. That's the reason that so many of our treatments are lined up by daily imaging, the way that we do the radiation therapy in these days. That's called image-guided radiation therapy. We always use image-guided radiation therapy when we're doing intensity-modulated radiation therapy, which is the most common way of treating prostate cancer these days. Another technique of treating prostate cancer with radiation is a permanent seed implantation, or radioactive seed implantation, also called brachytherapy. Brachytherapy just means putting the radiation where the tumor is. The application of radiation into the prostate gland is one of the most common techniques of actual implantation of seeds into the body for radioactive treatment. And it's become very common in today's world. Techniques of this were used back 30 and 40 years ago, but they were not very effective. The technique that was used was not very good and the side effects were rather significant. With the advances in computerization and ultrasound, there have been a lot of improvements in the way that we can actually get the radioactive seeds to the exact location within the prostate that we really want to implant them. And generally it only requires a volume study to measure the prostate gland and to make sure that we know exactly how many seeds need to go in and the pattern or arrangement of the seeds within the gland, and then a procedure that's done under anesthesia in the operating room to actually put the seeds into the gland. This is an example of the type of needle that we use to implant the seeds into the prostate. We tend to use anywhere from about 15 to 18 of these on the low side to as many as 35 to 40 in some extreme cases. It's rare that we would use more than 40 of these needles. The needle is placed by the urologist on the grid through the perineum, which is the section between the anus and the scrotum, and it enters the prostate gland. It only has to go about this deep to go into the prostate gland, and of course the patient is completely anesthetized during this procedure. The needle is placed, we check it with the ultrasound device. The ultrasound guide is just down here below the needle. We look at it on the ultrasound screen, And then we check a fluoroscope and we see the depth into the patient, and we check it then from several different angles, and then I reach over after the urologist and I both agree in the placement, and I grasp the trocar to hold it stable. I rest my hand against the device underneath it, and then the urologist takes this section and turning it like this to make sure nothing binds up, he slowly pulls back on that until the seed, which is in a strand of suture, is done, and then I take it and throw the needle away. You have the benefit of having two persons present for your procedure. The urologist and the radiation oncologist together check the placement of the needle, and then together withdraw the needle while holding the trocar, which drops the seeds off into a straight line in the prostate, because the seeds, whether it be 2 or 8, are connected in a strand of suture, which will then be resorbed by the body.